for this talk. Over to you, Rishi.
Thank you, Hitesh. And as usual, thank you, Orthopedic Principals, for giving me this opportunity to share some of my views on this important topic. So this is about selective nerve root blocks. So the other terminology for selective nerve root block is transforaminal epidural steroid injections. And we are going to discuss the basic principles, the technique, and how efficacious are these nerve root blocks in patients with lumbar disc prolapse. So the thing to note in this procedure is it is not specific for lumbar disc prolapse, even though most of the patients with acute disc herniations are the one who will be maximally benefited by this procedure. This technique can also be used in patients with moderate stenosis, facetal cyst causing unilateral radiculopathy as well. So if you take the topic of spinal injections per se, we can define spinal injections are those injections which are performed in and around the vertebral column, the spinal cord, and the nerve roots. So these injections which are instilled could be combinations or assorted injections of local anesthetics. For example, if you are giving a diagnostic pars block, it could be a pure local anesthetic like a lignocaine or a bupivacaine, or it could be steroids. A typical example is a depomedrol injection given for epidural steroid injection. The third thing is the dye, iohexol injection, which is given in patients with annular tears to identify the source of the back pain, and this procedure is called as cut discography. There are some procedures like the selective nerve root block where all three medications are concurrently used in this procedure. So these spinal injections could be diagnostic, therapeutic, or it could be serving both purposes. So we can classify spinal injections broadly, as we discussed earlier, as diagnostic injections, and those injections which develop as both diagnostic and therapeutic purposes. So diagnostic, the typical example is a discography. And in diagnostic and therapeutic injections, we have those given for pure radicular pain, what we call as sciatica in common parlance, and those injections which are given for patients who present with axial pain. So for radicular pain, the typical injection given is an epidural steroid injection. So here the purpose is to instill a steroid medication around the inflamed nerve roots. And these epidural steroid injections can be given through three routes in the spine. Either we can give transforaminally through a nerve root intervertebral foramen, or it can be given through the interlaminar route between the two lamina of lumbar vertebrae, or it can be given through the caudal route at the level of the sacral hiatus. Whereas those injections which are typically given for axial pain are the facet joint injections. And in this presentation, we are entirely going to focus on transforaminal epidural steroid injections, also called as a selective nerve root blocks. So this selective nerve root block has a typical classical indication, which is a unilateral radiculopathy. Patients who present with sciatica and in one lower limb, and very rarely in patients with bilateral radiculopathy, where one side of the symptoms is more severe than the other side. So the typical etiological reasons for this unilateral radiculopathy could be patients with an acute or a chronic disc prolapse, a lumbar canal stenosis, facetal cyst, and spondylolisthesis. So if you look at the basic pathogenesis of lumbar disc herniation, when the nucleus pulposus herniates out of the annulus and comes in contact with the spinal cord or the thecal sac or the nerve roots, what happens is our host immune system identify these nucleus pulposus proteins as foreigns, because as a foreign protein. Because when the spine develops, these proteins of the nucleus pulposus are not exposed to the thymus, and hence our immune system sees them as a foreign antigen when this nucleus pulposus herniates in a patient with a lumbar disc prolapse. So what exactly happens in a disc herniation is we get radiculopathy due to two important reasons. One is by actual nerve compression by the herniated disc fragment. Second is the intense inflammation around the nerve root. So the radicular pain produced by inflammation is actually more severe in patients with acute herniated nucleus pulposus, because of the autoimmune response. Whereas in conditions like chronic herniation and those with stenosis, it is more of a venous occlusion, congestion, which further results in inflammation and ischemia. The principle behind giving these nerve root block is when we give a local steroid around an inflamed nerve root, so it reduces the acute inflammation. So thereby we are able to break the pain cycle, and the mechanical compression produced by the herniated fragment automatically resolves over a period of time. So our aim is to reduce the pain in the acute symptomatic phase, which is beautifully enhanced by these steroids which are instilled around the nerve root. So they act through different mechanisms. So they inhibit the phospholipase A2 activity. They reduce the neural transmission in the pain-sensitive nociceptive C fibers. They reduce the capillary permeability, thus reducing the inflammation, and they also have a membrane stabilizing effect. So this selective nerve block is a popular and standard of care for patients with acute disc herniation in the Western countries. It's considered as our care procedure. Patient has the injection now and within an hour can go back home on his own. It has immediate analgesic effects because after we give the injection, we give a combination of local anesthetic as well as steroid. So the immediate local anesthetic acts over the inflamed nerve root, produces good analgesia, and the patient feels the procedure is working well for him. It is very cheap and it is done under local anesthesia. So which nerve root to target? So this is very important because we need to know which nerve root is exactly affected so that we are going to give the medication entirely around that particular nerve root so that it. For example, in any patient with a disc prolapse, there are two nerve roots which are closely associated with each lumbar disc. For example, if we take the L4 and the L5 disc, so the L4, L5 disc is placed somewhere here, and it is related to two nerve roots. One nerve root which is placed near the upper pedicle is called as the exiting nerve root, and the second nerve root which is closely associated with the inferior pedicle is called as the traversing nerve root. And when a patient develops a disc herniation, so the most common type of disc herniation is a posterolateral disc herniation, which happens in the lateral recess. So whenever there is a disc herniation in the lateral recess, so the nerve root that is getting affected is the traversing nerve root. So when a patient is having an L4-5 disc prolapse and it turns out to be a posterolateral disc herniation, we need to target the L5 nerve root. So this principle is very important because we don't need to give the injection in the L4-5 interforaminal space, whereas we need to give the block under the L5 pedicle to capture the L5 nerve root, which is maximally inflamed. So our aim is to target the L5 nerve root in patients with a classical posterolateral disc herniation. So where exactly are we going to place the needle? So for this, there is a phenomenon called as a safe triangle. So how to draw the safe triangle? So when we take a APCM picture, there is a line which can be drawn tangential to the lateral margin of the pedicle. Another line which is drawn tangential to the lower margin of the pedicle. And there is a hypotenuse which passes obliquely from inferior and lateral from the medial quarter of the pedicle laterally. So the space between this region is called as the safe triangle of the intervertebral foramen. And this is the place where the maximum inflammation is happening. And that's where we need to point our spinal needle and where we need to instill the steroid. So let me show further about the safe triangle in the actual CM picture. So this is the pedicle of the L4 vertebra. This is the pedicle of the L4 vertebra on the right side. So this is the facet joint and that's the transverse process. So the nerve root is passing just below the L5 pedicle. So the green structure is the nerve root and we want to place our injection or the needle just lateral to the nerve root in the safe triangle. But actually, if you see, this space is completely covered by the pars region and part of the lamina. So we may not be able to insert the needle under this pars region if we have to target the inflamed nerve root. So that for that, what we do is we have to rotate the spine. So we have to get an oblique view of the spine so that we can see the nerve root in a better perception. So when we give a nerve root block, the first thing to do is to get an oblique view to get the Scotty dog appearance. So this is the typical Scotty dog appearance. So if you have to block the right L5 nerve root in a patient with the right L45 post-lateral disc collapse, you have to get a right side oblique view. So these are the structures which we see in a Scotty dog: the eye of the dog, the neck of the dog, the mouth of the dog, the ear, and its foreleg. So the nerve root is passing somewhere here, and this is the place where we need to pass our needle, right? So that is the place. So to localize it on the skin, I have placed a 18 gauge needle over the skin, and at the tip of the needle, I am going to pass the first step is to pass the hypodermic needle to numb the skin over that region. Next, I pass the spinal needle in the same direction under the pars region to block the nerve root. So I confirm it in the C-arm that I am in the nerve root foramen. And then I give a dye to make sure that the dye is tracking along the nerve root to make sure that I am in the correct place. And once this is confirmed, we give the final drag. So this is the final cocktail that will be given, which will be a 80 milligram of triamcinolone along with 2 ml of 0.5% bupivacaine. So if you give more bupivacaine, there are chances that the patient can have a temporary weakness of the involved in nerve root. So it's better to avoid more than 2 ml of bupivacaine. And triamcinolone, we can give either 80 milligram or 160 milligram. So 80 to 160 milligram, both work effectively in every patient. So let me show a video where exactly in a practical situation, how we give a nerve root block. So this is a patient who has a recurrent L4-5 disc prolapse, and he presented with a recurrence of pain on the left leg with severe radicular pain. There was no pain on the right side. So this is at the L4-5 level. So the L5 nerve root. So this is the same thing which I had explained. So this is the L5 pedicle and this is the L5 nerve root. So if you have to block the nerve root under the L5 pars, I have to pass the needle obliquely like that. If I pass straight away, I'll be hitting the lamina. So to see the foramen under the pars, we need to get a oblique view. So this is the imaginary oblique view, also called as a Scotty dog view. So that's the ear, that's the posterior part of the Scotty dog. And now we are able to see the nerve root end on. So first I take the local anesthetic with the lignocaine. Next is the iohexol, which will be 2 ml solution. And third syringe will be steroid with bupivacaine. So these 3 syringes are pre-filled and kept ready so that we go ahead with the procedure. The patient is awake and kept prone. The first thing to do is to get a C-arm view, and the C-arm should be tilted cephalocaudally to get the L4, L5 disc space parallel to each other. So now the disc space and end plates are parallel to each other. The next step is to get the Scotty dog view. So now we have got the Scotty dog view, and I have placed the hypodermic needle over the neck of the dog, and I give a local anesthetic injection to numb the skin and the fascia. So once the hypodermic needle is passed, we wait for 30 seconds. And then next thing to do is to pass the spinal needle. So we take a 20 or 22 gauge spinal needle and then pass gently, check it in the C-arm continuously. So you can see the tip of the needle is facing laterally here. And I want to insert it more medially under the pedicle. So I'm redirecting it again. Yes, so now the tip of the needle is passing under the neck of the Scotty dog. So once I pass about 50 to 60%, I get a lateral C-arm picture to make sure that we are entering into the foramen. So once the needle has entered into the foramen, we get an APV again, and now we give the dye. So this dye gives a confirmation that our needle is close to the nerve root. So that's a nerve root we can see tracking from the pedicle and distally down. Once this is done, the patient will also have reproduction of pain, exact same pain which he had been having before, and then we give the final steroid injection. So what do we do after giving the injection? The patient can be mobilized. The patient can be made to walk within 30 minutes after the procedure. And usually they go home within 1 or 2 hours. We should also make sure that there are some patients who will be hypersensitive to the lignocaine or the bupivacaine which are injecting around the nerve root. So they can have a new onset numbness or subtle weakness of the nerve root. So it happens in about 5 to 10% of the patients. So this will usually revert within 4 hours. So if such a patient has some weakness, just keep the patient for 4 hours for the anesthetic effect to wean off, and then you can mobilize the patient and then discharge them. Usually they can return to normal work from the next day, and we usually review them at 6 weeks time. So this technique where we get a oblique view can be used for all the nerve roots from L2 to L5. So if you have an L1, L2 disc collapse, you can block the L2 nerve root. L2-3 disc collapse, you have to block the L3 nerve root, and similarly for L3-4 and L4-5 disc herniations. So if it is a posterolateral disc collapse, the common type of disc herniation which we see, we have to target the traversing nerve root. For example, if it is an L4-5 disc herniation, target the L5 nerve root. Whereas if it is a foraminal or a forelateral disc herniation, as we see in this picture, then typically the exiting nerve root is the one which is going to get compressed. So we have to target the exiting nerve root. So in a situation of an L4-5 disc collapse in the foraminal region or the extraforaminal region, try to block the L4 nerve root. In rare situations, you have a posterocentral herniation, but the patient will have typically more symptoms on one side. In such a situation, target the more symptomatic side, again the traversing nerve root. The other common doubt that occurs in our mind is, can we inject 2 nerve roots? So it's quite common to see patients who have 2 adjacent level herniations, an L4-5 herniation and L5-S1 herniation. Usually both of them will be on the same side. And if you're not willing to operate, or the patient is not keen to have a surgery and you want to give a nerve root block, you can give a therapeutic nerve root block at both the levels. So for example, this patient had a herniation at L3-4 and L4-5 level. So we have to block the L4 and the L5 nerve root. So that's the corresponding pedicles, and this is the oblique view of the spine to see the L4 and L5 nerve root. And as you can see, I have placed the needle close under the safe triangle, and the dye clearly shows that those 2 nerve roots have been completely blocked. So a successful transforaminal injection, when do we say it is a successful selective nerve root block? The first thing is, make sure that you are able to correctly localize the involved nerve root by clinical and MRI correlation. So clinically, you examine the patient has typical pain going along the back of the thigh into the calf region with numbness in the first web space, and you take an MRI. MRI shows a posterolateral disc herniation on the same side at the L4-5 level. Then you have a good localization based on clinical and MRI diagnosis. The second thing is, you should have a good correlation between what we see in the MRI and your C-arm position. This is a problem in patients who have sacralized segments. So in that case, you should be clear that whether you are targeting the L4 nerve root or the L5 nerve root in such situations. Third thing is correct needle insertion. Get a good Scotty dog appearance and then localize your spinal needle exactly under the neck of the dog, and you will not be able to miss the affected nerve root. So if your needle position is appropriate, when you inject the dye, you get an appropriate radiculogram, and correspondingly, the patient will also tell that the pain which she had been having before has been reproduced when you inject the dye. So if all these factors are present in the patient, then this nerve root block the procedure has been executed well by the surgeon, and the patient is likely to reap the benefits. So other common questions or other common doubts that we have is, how frequently can we inject? So for correctly chosen patients, this nerve root block procedure in patients with acute or a chronic disc herniation has a very good success percentage, more than 75%. But after 6 weeks or 3 months, if the pain recurs, there is no harm in repeating the injection, especially if the pain is not very unbearable for the patient. But conventionally, we don't give more than 3 injections in 1 year. This is because whatever steroid injections we are giving are particulate steroids, and they tend to get deposited around the nerve root, close to the inflamed disc and the nerve root. So if at all the patient comes for a surgery later on, there will be a lot of adhesions around the nerve root, making the surgery difficult. So what I advise my patients is, if they are not getting good pain relief after 2 injections and they continue to have the pain, it's better to consider surgery rather than persisting with further nerve root block injections. The other scenario is, if there is no relief after the first injection at 1 week, or within 6 weeks time, the pain recurs again, then again, there is no point in giving the root block again, because in the first instance, you have given it properly, it has not worked for the patient. Either the mechanical compression is severe or the amount of inflammation around the nerve root is too severe to be treated conservatively. And in such patients, the options of surgery should be discussed. So the other common doubt is how to reach the S1 nerve root. So by anatomy, we know that. So this is the L5 vertebra and this is the sacral region. So if there is an L5 S1 disc herniation in the posterolateral space, the S1 nerve root is going to be affected, which is going inside the sacral bone. But if you get an oblique view, we may not be able to see the foramen here, because this sacral bone is completely covered in the front as well as on the sides. So this is the section of the sacrum. So as you can see, so there is a disc herniation on the right side at the L5S1 level, and we have to block the S1 nerve root. And where we are going to block is at the sacral foramina. So our aim in these patients with an L5S1 herniation is to not to get an oblique view to go under the pars, whereas we have to look for the sacral foramina where we can block these nerve roots. So this is another video where a patient with an L5S1 disc herniation on the right side is going to have a right S1 nerve root block. So this is the MRI of the patient. So there is a posterolateral disc herniation on the right side. So this is a schematic picture. So there is a L5 vertebra proximally. So that's the pedicle of L5 vertebra. And that's the pedicle of S1 or the sacral bone. So we have a disc herniation on the right side in this patient. Assume that the patient is lying prone in front of you. So the S1 nerve root, which is going just posterior to the nerve root, is getting pressed. So as I said earlier, so this region is completely covered by bone, but where we can catch the nerve root is looking for the sacral foramina, the posterior sacral foramina, right? So in a live situation, you will be able to see the sacral foramina like a cat's eye. So if you are not able to see the cat's eye, then this procedure is going to be difficult. Again, the patient is lying prone, so she is awake, lying flat on the CM table. So here the only adjustment that we need to make is the cephalocaudal tilt. So for the lumbar lordosis, the CM has to be tilted cephalocaudally so that we will be able to see the sacral foramina clearly. So the table is tilted about 20, CM is tilted about 30 degrees. Now you see the sacral foramina clearly. That's where we want to give the nerve root block. So if you see the foramen clearly, then almost 90% of the procedure is done clearly. So this is our setup. So first will be the lignocaine injection for the skin. Second will be the dye. And third thing will be the steroid. So I place the thick needle to localize the nerve root foramen. So look at both the live picture as well as the CM picture. So the needle tip is on the skin. So that's where I'm giving the local anesthetic injection to numb the skin and the fascia. I wait for 30 seconds. So my needle is just distal to the foramen. So when I pass my spinal needle, I want to direct it little bit cephaloid. Again, I have gone in the same direction. So I am trying to pass the needle little cephaloid. Right, so now I have gone close to the center of the foramen. So I am advancing the needle further And when I get a giving away sensation, I get a CM picture. So that's a lateral CM picture which shows that I am inside the sacral canal. So that's where I want to be in this patient. So I don't want to further advance the needle. So now I give the dye to confirm the position of the needle and whether I am just around the nerve root. Yes, then dye shows that I am around the right sacral nerve root, close to the pedicle. So once this is confirmed and the patient also says there is reproduction of pain, we give the drug, a combination of triamcinolone and 2 ml of 0.5% bupivacaine to complete the nerve root block. So as discussed earlier, so the transforaminal or the selective nerve root block is given in the foramen. There are two other ways where we can deliver steroid injection epidurally around the spine. So one is the caudal injection and another one is the interlaminar epidural. So the interlaminar epidural, just a brief word, it's commonly considered as anesthetist epidural injection. So the interlaminar space, typically at the L3-4 level, it's used through a midline approach. So they use a loss of resistance technique to pass through the ligamentum flavum. And once they reach the epidural space, they give the drug. So here a fluoroscopy is not used and the needle is given inside the epidural space by experience and loss of resistance technique. The second technique, third technique is the caudal epidural injection. Here the injection is given through the sacral hiatus. The sacral hiatus is actually a bony defect in the midline at the level of the S4 and S5 lamina. So we palpate the sacrum from proximal to distal, and wherever we palpate a defect, wherever we feel a dip in the sacral bone and the patient is lying prone, that's the place where we insert the spinal needle and then we give the drug. Since the drug has to pass a long distance from the sacral hiatus, it has to reach the L3-4 or an L4-5 disc herniation. We need to give a lot of drugs. So along with the steroid and the bupivacaine, we add a lot of normal saline also so that the drug passes proximally. But this is a very simple and safe technique where the risk of injuring a nerve root or entering into the thecal sac is much less. So the risk of dural puncture is very, very nil in these patients. So comparing between these three different techniques of epidural injection, the first one, the transforaminal, which we discussed for the whole duration, is the highly specific technique for patients with unilateral and acute lumbar radiculopathy. It has very high efficacy because we are targeting all the medication that needs to be given exactly over the nerve root which is affected. The second technique, the interlaminar, is slightly less specific because it's whether the herniation is at L2, 3, 4 or at the L5S1 level, the injection is given at the level of L3, 4 and the drug spreads. It spreads proximally as well as distally. So the amount that needs to reach at the level of the inflamed nerve root is much less. But this is very useful when the patient is having a bilateral radiculopathy or if there is a existing significant axial pain also. In those situations, an interlaminar epidural injection may be preferred. The third one, caudal, is the least specific one. Like I told, whether you have herniation at L2-3 or at L5S1, we give it through the caudal route and the drug is expected to reach proximally. If it doesn't reach, the drug is not going to act at the level of the inflamed nerve roots. If you look at the outcomes as per literature, it has very good results, almost 70 to 80% at 2 weeks. And up to 1 year, these successful results have been retained, especially in patients with acute single-level unilateral radiculopathy. So we also did a study, a prospective study in about 91 patients who had a selective nerve root block. So these are the patients who had failed conservative treatment and who opted for a selective nerve root block instead of a surgical intervention. So these were consecutive patients and we followed them for 1 year. So at the end of 1 year, we found that among these 91, 69 patients had good pain relief. So their VAS score was almost 1 from a score of 8 or 9 before having the injection. And this was maintained at the end of 1 year. So we had a success percentage of almost 76%. Only 22 patients had a failed nerve root block. So despite the root block, they continued to have pain or they had a recurrence of pain very soon and they had to be operated with a microdiscectomy. And when we analyze what are the factors why these patients ended up in surgery and why in these patients the root block didn't work, where number one, excessive sensory symptoms. So if the patient is having too much of paresthesia at the first instance before giving the nerve root block, then they were unlikely to become better with the nerve root block and they underwent a surgery. Patients who had a very high ODA score at the start of the disease. Patients who were in a non-manual job. So this was like a paradox. So patients who were in manual job went back to their manual job after the root block and they didn't undergo a surgery. Whereas those who are in a white collar job typically required a surgery, and in these patients, for unknown reasons, the root block didn't work. The factor which we found with very high significance was presence of a lumbosacral transitional segment at the level of the herniation. So these are the patients who had a very poor result with selective nerve root block and they ultimately required surgery. The last thing what I have written is a splash pattern of radiculogram. So what we did was whenever we had the dye injected after the needle placement, we observed that not all patients had a uniform type of radiculogram, and it was of typically 4 different types. So some of these patients had an arm type, like an arm of a shirt, as we see in the first picture. Some of these patients had a linear pattern, like a streak of dye, either on the medial aspect of the nerve root or on the lateral aspect of the nerve root. This we call. The third group had an arrow type pattern. So they had one streak which went up and another streak which went down. And the fourth group, despite having a proper placement of the needle and the reproduction of pain, they had a splash pattern. So the drug, instead of going proximally and distally along the nerve root, had a splash pattern in the C-arm picture. We found those patients with the splash pattern had a poor outcomes compared to the other 3 types of radiculogram. So we have discussed a very important technique called a selective nerve root block. So this is a very simple and easy technique. And the thing which needs to be noted is we regularly see patients with lumbar disc herniation who have very severe pain in the acute phases. So whenever we give them medications or put them in traction, it takes at least 2 to 3 weeks for the acute painful episode to come down. And in that 3 weeks time, the patient is having excruciating pain. So these are the ideal candidates for whom these nerve root blocks can be given. And interestingly, this has a very short learning curve. So it's not a very complicated technique. And even if the needle placement is not very accurate, the amount of complications which you can get with this root block is very, very minimal. So it's a very less complicated technique. And if you are able to master the technique with good attention, so the 5 things which we discussed for a good outcomes were correct reading of the MRI and correlating the MRI with clinical presentation, and C-arm picture should match the MRI, targeting the correct nerve root, place the needle in the correct position at the proper safe triangle under the affected pedicle, and then get a good radiculogram. When you inject the dye, get a good radiculogram. So there are a lot of people who don't inject the dye. So if you get a good radiculogram, it gives a confirmation that the needle has been placed properly. And if the patient also says there is a reproduction of pain when you inject the dye, then it means that you have done the procedure effectively. And when we give the final cocktail, so these patients should have a good outcome. Thank you.
Thank you, Rishi, for yet another fantastic presentation. And I'm really happy to see your publication in the Global Spine Journal on the different types of radiculogram. A few questions. One is regarding the diagnostic accuracy of these selective nerve blocks. If I can quote a publication by Rebecca Ben in BMJ Open last year, they looked at the sensitivity and specificity of these selective injections. They looked at large number of patients, 361 patients from 6 studies, and they found that the accuracy is not well enough, and they doubt whether it's useful. What is your take on that?
Yeah. So the common mistake that is done by the people who perform this root block is there are a lot of people who are involved in this. It's not only the spine surgeons who give these nerve root blocks. So it is also performed by anesthetists. It is also performed by pain physicians. It is also performed by radiologists also. So there is a lot of importance that should be given for clinical correlation. So like I told, the first important thing to achieve success in this root block is you have to make a clinical diagnosis of which nerve root is likely to be affected, and that has to be correlated in the MRI. So if there is a disc herniation on the right side and the symptoms are on the left side, then these are not the candidates who are going to get benefited from this procedure. And when we look at these studies, they include all patients with sciatica, all patients with unilateral radiculopathy. So those are not the ideal candidates to undergo this root block. So my ideal patient is the one who is having an acute disc herniation on the unilateral side, either a posterolateral or a foraminal one with excruciating pain. And these are the best candidates to undergo this nerve root block. And more usually I give it as a therapeutic procedure. So the role of these root blocks as a diagnostic one happens in only one situation, that is in patients who have 2-level or 3-level herniation, and you're not able to decide which level you would like to operate. So because young patients, you don't want to operate at 2 or 3 levels, so you want to target this level as the symptomatic one. So in that situation, what we do is we place the needle and give only the local anesthetic. We don't give the steroid. We give the local anesthetic and ask the patient, just wait for 20-30 minutes and see whether that particular block worked for that patient. So if it doesn't work, probably that's not the nerve root which is affected.
Rishi, thank you for that. The other question is, what is the situation with the NICE guidelines regarding these selective nerve blocks?
So, like I told, in Western countries, it is one of the most commonly performed procedures, because if you take patients with disc herniations, the absolute indication to operate on these patients are those who have a Caudal syndrome and those who have a progressive neurological deficit. So the rest of the patients, they expect to become better over a period of time. So if we go through our literature also, a lot of patients, almost 80 to 90%, even though they have an acute disc herniation, they become better over a period of 2 to 3 months time. Our aim as surgeons is to take care of them in the first 2-3 months of excruciating pain phase. And in that phase, what we usually so far have been doing is pump them with a lot of medications, keep them bound to bed, put them on traction. All those things, it's demoralizes the patient. Becomes the moment the patient becomes bedbound, they become psychologically depressed also. So, but these are the patients who will be very much benefited by this nerve root block. Once we give the root block, their ability to tolerate the pain, move around is much better. And once the pain cycle is broken, they do really well. And in UK, this is a standard procedure, and this is where I learned the technique also.
Rishi, for that. The other one is regarding the radiculogram. Fantastic paper, and I'm really happy for that new classification. How do we really get to know that it is in the nerve sheath or not? Because what if the splash pattern that you saw is because that your needle was totally a little bit off where you wanted it?
Yeah. So, like I told, the fourth point in the successful root block is accurate placement of the needle. So, even though we try to place the needle in the proper position in all the patients, the radiculogram what we saw in the CM picture was different in different patients. So, some I told like it had an arm pattern, it had a linear pattern. Some of them had an arrow, and very few had a splash pattern actually. So the splash pattern and like I told, had a poor outcomes, and these are the patients who needed to have a surgery. And during surgery, what we observed was these patients had extreme venous adhesions around the nerve root. So when we place the needle, probably the dye has gone in and around those vascular adhesions that what gave them a splash pattern. So this placement of the needle has been studied in several cadaveric studies, and they found that if you place the needle inside the dural sheath, so every nerve root will have a dural sheath. So if you place the needle inside the dural sheath, it has a very good radiculogram, but those patients had extreme postoperative pain. So that's not the correct way to do it. It has to be placed around the nerve sheath. The needle should not pierce the dural sheath. That's the aim of the procedure. So how to know that whether we have actually entered the sheath or we are staying away from the sheath is by talking to the patient. So you talk to the patient continuously during the procedure, and moment you poke the sheath, the patient will wince with pain. And that's the time you need to pull out the needle by 2 or 3 millimeters so that you don't injure the nerve root.
Okay, Rishi, thank you for that. I think there are no more questions. Rishi, thank you for the fantastic presentation, and really happy for your publication. Congratulations for that. I'm sure a lot of people are going to cite this in future publications as well.
Thanks, Hitesh. And I think, like I told, very useful technique, simple and easy to learn. And this is a very common problem which we see in the outpatient clinic. So every orthopedician, whether he is a specialist in arthroplasty or arthroscopy, back pain and radiculopathy due to disc herniation is a commonly faced problem. And this technique has very good results. So I wish everybody learns from this presentation and would be able to imbibe this thing in their practice. I would be happy for that.
Now, Rishi, before you conclude, just one last minute, I forgot to ask about it. How much is because you take moving shots on the CM, isn't it? So do you think the exposure, radiation exposures, how much is it?
Yeah, at the maximum, it will be maximum 10 shots.
Okay. Do you take a movie or it's just standard?
No, just single shots.
Okay. Okay, Rishi, thank you very much for joining us. And it was lovely listening to you as usual. And we can hold one more lecture later on when you have time.
Yeah, sure. Thanks. Thank you, Hitesh. Thank you.
Thank you very much.